Good morning, everyone. Welcome to Grand Rounds. We'll give folks a few seconds here to kind of file in virtually from the waiting room and get started. It's now September 21st, and this kicks off, actually September 15th kicked off Hispanic Heritage Month. And so you'll actually see in the chat a link if you would like to download the Zoom backgrounds. And so we'll be announcing different events as well at Stanford Medicine. If we have the first slide, please. So I wanted to give a big shout out and thanks for everyone who came and showed up for our annual Women in Medicine photo. We had a virtual version as well as an in-person. You could see us, many selfies were had after not seeing folks for a long time in person. Thank you for that. And you'll see actually Zoom backgrounds with those photos available on our website as well. Next, wanted to announce just keeping your eye out for the various posts in our newsletter. I think you've seen so far this month the posts from Jocelyn Hollings, Dr. Diana Farid, and Dr. Christine Santiago is this week in the newsletter for her family and loved ones. It's her title. And she also talks about the health equity program in our residency program, for our medicine residency program. And you can see other posts of folks featured as well. Sarah Chobot, one of the PAs in our Division of Primary Care and Population Health, and our own Lisa Marie Mejia in the Department of Medicine team. Next slide, please. And then I wanted to congratulate Dr. Angie Chen. Dr. Chen is a clinical associate professor in the Primary Care and Population Health Division, and this weekend was the annual Women in Medicine Summit in Chicago, and she won the annual award for resilience. And so if you see Dr. Chen, please give her thanks. This is actually a shot from Dr. Salas, who was at the award ceremony, of Dr. Chen receiving her award virtually in true hybrid fashion. And so again, congratulations to Dr. Chen. Next slide. I'd like to have Dr. Jesse Markovitz join us. Dr. Markovitz is a faculty member in our Division of Hospital Medicine and our Department of Medicine representative to the Lactation Council in the Well MD Center. Dr. Markovitz.
Thanks, Dr. Harmon. Thanks for having me today. I just wanted to share a new resource that was available through the Well MD program for parents returning to work who are lactating after the birth of a child. So this website, we'll tweet out the link for it and we can put it in the chat as well, is available on the WellMD Well PhD site. And the two main updates are that we've compiled a list of lactation spaces. That's the slide on the right. This is a searchable resource for people to find spaces where they can pump. You can search it by location. It's alphabetical. You can download it. You can also put in the global search tab for a building that you're looking for. And so that's available. And then the panel on the left, the frequently asked questions, includes information about accommodations for lactating individuals, who to speak with, and also just some practical information about pumping, what you'll need, supplies, things like that. From the department level, we'll have more updates in a future faculty meeting. If there's questions in the meantime that people have about lactating and pumping at work that your division manager or HR are not able to answer, please feel free to reach out to myself or Dr. Harmon for more information. We'd like to help support our lactating parents as much as possible. Thanks.
Great. Dr. Markovitz, thanks so much for that. And I just wanted to briefly say, I don't have a slide on this, but as you know, in just a little bit, we'll have CME credits sent out to you like we do for pretty much every session that we can offer CME for. We will starting next week offering also one MOC credit if you would like to get that as well for every Grand Round session. So just want to give a heads up of that. I hear a lot of faculty members like myself are always looking for MOC credits. And so I'm happy and really thankful for our CME office for being so supportive of that. So we'll have more information on that next week. If you have any questions, let me know. I do, while I'm speaking, just want to say again, a special thank you to our leaders, Dr. Harmon, particularly for helping us set up these sessions, Dr. Dunn, Caceres, Dr. Salas, for helping create this amazing lineup this month to celebrate not only Women in Medicine Month, but also National Hispanic Heritage Month as well, that we get to celebrate today. So thank you to them for setting up this great lineup. And I will now, Dr. Harmon, turn it back over to you. And I believe Dr. Dunn is also going to speak next. Thanks a lot.
Yes, Dr. Dunn will be joining us for some announcements. She's our Associate Chair for Diversity.
Good morning, everyone. Happy Women in Medicine Month and happy Hispanic Heritage Month. First of all, I do want to take a moment to shout out Dr. Stephanie Harmon, our Associate Chair for Women, in just helping to make this month special for our community. Thank you for all of your efforts. It's been amazing thus far. I am pleased to announce some upcoming inclusion rounds. If we could have the next slide, please. First, we are going to have on October 3rd from 12 to 1 via Zoom. You can scan the code there to register. There will be a panel celebrating Disabilities Employment Awareness Month. And that panel is going to be moderated by Holly Tabor and will feature Joseph Garner, Margarita Becker, Suchi Rostagi, and Kevin Mintz. And that is going to be entitled Navigating an Academic Career with a Disability. Next, did you know that October 11th is National Coming Out Day? Well, we have two exciting events for that October 11th. The first will take place at 11:30 a.m. and will feature Ballet Folklorico Colibri. And that is going to feature a performance by that group, which has the mission to promote the pride of identifying as an LGBTQ+ Latinx person through the art of folklorico dance. After their performance, they'll have a short Q&A session. And then at 12 p.m., and by the way, that's going to be in the Grant Courtyard, 11:30 to 12. Immediately following that, there will be an LGBTQ+ health panel from 12 to 1 in M112 or via Zoom. That's going to be moderated by our own Dr. Wendy Caceres, who is an Associate Chair of Diversity and Inclusion, as well as featuring panelists Dr. Benji Laniakea and Dr. Leslie Subak. Next slide. Finally, we have the 1619 Project continuing series. We'll be talking about episode 3, which is the birth of American music. Again, the code is there for you to scan, and we hope you will join us in what promises to be a stimulating conversation about slavery, our nation's history through the lens of slavery and how it shaped our nation today. That's going to be on October 24th at 5 p.m. via Zoom. We hope to see you there. And finally, we have upcoming grand rounds. Again, celebrating Women in Medicine Month and Hispanic Heritage Month. This is going to be an in-person grand round, and that will be at LKSC room 120, as well as available via Zoom. And we will have Dr. Elena Rios, who is the president of the National Hispanic Medical Association. We hope to see you there. That's going to be on September 28th, next week. And now it gives me great pleasure to introduce Dr. Andrea Jonas, who will be introducing our speaker. She's clinical assistant professor in the Division of Pulmonary, Allergy, and Clinical Care Medicine here at Stanford. And she is the associate program director for the Stanford Internal Medicine Residency, as well as the Pulmonary and Critical Care Fellowship. Dr. Jonas?
Thank you so much, Dr. Dunn. And I, in turn, have the pleasure of introducing our Medicine Grand Round speaker today, Dr. Monica Vela. We are delighted that she's here. She's joining us from the University of Illinois College of Medicine, where she is a professor of medicine and director of the Hispanic Center of Excellence since 2021. She is the former Associate Vice Chair for Diversity and Associate Dean at University of Chicago Pritzker School of Medicine, where she spent 16 years directing coursework and health equity, advocacy, and anti-racism for medical students, the only course known to improve diversity of the medical school applicants and to improve the cultural climate among medical students. Among her many leadership hats, she serves as the associate editor for JAMA Network Open. She serves as the member of the AAMC Committee for Holistic Review, and further is an ACGME Equity Matters program facilitator. Her research work spans medical education on health disparities and care of limited English proficiency patients, as well as diversity in the medical profession. This has led to over 50 peer-reviewed articles in such journals as JAMA, Lancet, NEJM, and Academic Medicine. She's been awarded ACP's National Award for Diversity and Access to Care, the Society of General Internal Medicine's National Herbert Nickens Award for Diversity and Minority Health, and the inaugural AOA Fellow in Leadership Award. The University of Chicago, she was further honored with the Distinguished Faculty Award for Community Service, as well as the Diversity Leadership Award. We are absolutely delighted that she is here, and I will turn it over to Dr. Vela.
Thank you so much for that kind introduction and also for the opportunity to be with all of you here today. I have to tell you that I was absolutely stunned by the offerings that Dr. Dunn described for Women in Medicine Month, as well as Hispanic Heritage Month. You really have it going on and makes me want to wish I was there with you to see Ballet Folklorico. Fantastic work. The title of my talk today is Structural Violence Against Hispanics in the United States. And as you heard in the introduction, I spent most of my training as well as early career at the University of Chicago, enhancing diversity and teaching on health equity and creating a climate of inclusion. This past year, I underwent a big transition, not only because I became an empty nester, but also because I transitioned to the University of Illinois in Chicago and took on the leadership position for the Hispanic Center of Excellence. This move was driven by a number of personal issues. The biggest is that I'd like to dedicate the next decade of my career to my parents, who were Mexican immigrants to this country with about a 5th grade and 9th grade education, had 5 children, and dedicated their lives to making sure that we had access to education. And so I'd like to speak to you today with no conflicts of interest, and make sure that I am able to define structural violence, to list mechanisms of structural violence against Hispanics or Latinx in this country, and then recognize opportunities given the power that we have as medical professionals to dismantle systems that continue to uphold that structural violence. As I move forward, I hope to thread this talk with themes of injustice that truly never leave us and center us back on our profession and our moral and ethical responsibilities. First, a definition. I'll start, I am going to actually this away a little bit. There we go. I'll start by actually defining structural violence. It's actually an older term established in the 1960s and established by Latin American liberation theologians, specifically Johann Galton, who felt that they needed to permanently implicate the Catholic Church as well as European colonizers, and call for the Catholic Church to participate in a social justice mission to end inequities in Latin American countries. The term was actually made quite popular by Dr. Paul Farmer, and he defined it in this way. Structural violence is one way of describing social arrangements that put individuals and populations in harm's way. These are structural because they are embedded in practically everything that we do in this world. They are violent because they cause injury to people when neither culture nor individual will is at fault. And we need to recognize that these structures are embedded because of historically given and often economically driven processes that conspire to constrain the individual agency. The biggest message I think to take away from this slide is that when we describe or define structural violence or find mechanisms of structural violence, it is incredibly difficult to point to any one individual or any one organization and place them at blame, because these structures are so embedded in everything that we do and in our societal norms. It is very difficult to tease apart who is to blame at this point. Dr. David Williams points to immigration policies as a form of institutionalized racism that contributes to structural violence because they trigger hostility toward immigrants, because they create psychological distress. And they create this distress not only for those who are directly targeted, but for their family members, for their neighborhoods, for their communities, and those around them. They lead to reduced utilization of preventative services as well by all immigrants, whether they are documented or undocumented. This is one of those ongoing traumas that never really leaves us, the trauma of deportation. And while it had been ongoing for centuries prior to the Wickersham Commission, I hope that many of you will take the opportunity to explore the history of the Wickersham Commission, which was federally appointed in 1932, reviewed deportation policies, and found that in their quote, "the apprehension and examination of supposed aliens are often characterized by methods that are unconstitutional, that are tyrannic, and that are oppressive." And that there is a growing literature today within the social literature and also the medical literature that examines the effects of US immigration policy on immigrants, in particular Latinx immigrants, documenting links between immigration policy and healthcare utilization, Medicaid participation, food insecurity, psychosocial well-being, self-rated health, and enforcement-related distress. All things that as medical professionals, I hope that we are invested in changing. To drive this point home, I'm going to give you a story of Postville, Iowa. Postville, Iowa is a tiny town of about 2,000 people. Somewhere in May of 2008, a major federal immigration raid went on in Postville, Iowa. You can see the picture there on the right upper hand corner, and there are many other pictures that are quite traumatizing that I chose not to include today. Without advance warning to officials, ICE deployed nearly 1,000 agents. Remember, there are only 2,000 people in this town, using military tactics, including armed officers, a UH-60 Black Hawk helicopter, to arrest around 389 employees in the one factory located in Postville, Iowa. It was a meatpacking factory. 98% of the employees were Latino, and they handcuffed all employees who on spec they assumed to be Latinx until their immigration status was verified. Here are some themes that you'll see commonly when it comes to deportation and immigrants. The raids separated hundreds of families. There was fear of follow-up home raids, keeping families from staying in their own homes. Children were separated from their adult family members. And news of the raid immediately spread throughout the state, but immediately spread through particular mechanisms, in particular Spanish newspapers, including La Prensa, a Spanish language newspaper in Western Iowa that published eyewitness testimony of arrestees detained at a cattle fairground, cuffed and chained together from the waist to the ankles. And so we have to take a step back and ask, apparently people were following the law, but who really suffered here? And in 2008, of the 389 people who were detained, 306 were criminally charged. It ended with 297 of them given 5-month prison sentence and sent all the way across the country to serve their time under the supervision of the Federal Bureau of Prisons. So here's that theme of separation of others based purely on documentation. By 2010, a certified Spanish interpreter reported that the guilty pleas were obtained under duress. By 2012, the over 9,000 counts of child labor violations were dropped to 83. And why? Because the court system found that they were too expensive to prosecute. Also by 2012, the owner was sentenced to 27 years in federal prison in order to pay over $26 million in restitution. However, by 2017, President Donald Trump commuted that sentence. And so we have to go back and ask who suffered here. And it was not just the families that were separated. Thankfully, we have researchers doing the work and collecting the data and disseminating the data to demonstrate how far-reaching the suffering is. This is a study that was published by Dr. Aresha Martinez Cardoso, demonstrating the rates of low birth weight before and after the post-Vil raid by mother's ethnicity or nativity. As you can see, the low birth weight rate for US-born Latina mothers dropped slightly, whereas that for foreign-born Latina mothers rose significantly. But you'll also note that for US-born Latina mothers, the rate also significantly increased. And so we learn that racialized stressors affect not only the health of Latinx immigrants, but also US-born co-ethnics. And if you look further in the literature at neighborhood violence, whether it is witnessed or unwitnessed by residents, all residents are affected psychosocially, and the health of populations drops when racialized stressors occur. And so we move forward to present day because, again, this injustice does not leave us. And we have all recently heard of the asylum seekers that were sent to Martha's Vineyard. The term relocation was used, but we know, because of the history of structural violence in this country, that while people would like to use the term relocation, this was really separation and then repeated internal deportation. We will find out in the years to come who has actually suffered here, when the violence started and when it will end, because it will be far-reaching. We will learn again what messages we are sending and who those messages actually reach. I'll move on to another form of structural violence, that of reproductive injustices. We all have learned at some point of Francis Galton, who wrote Hereditary Genius. He was the first to declare that intelligence was heritable, but we often forget Lewis Terman, who was actually at Stanford, who wrote The Measure of Intelligence and wrote in the early 1900s that intelligence was not only hereditary, but directly correlated to morality, crime, and poverty. And he went on to further recommend that institutionalization and sterilization be for the unfit. What was the outcome of this declaration, this scientific racism that became the basis for eugenic movements moving forward? Well, very unfortunate consequences for what he noted to be Spanish, Indian, and Mexican families of the Southwest, and also Negroes. He wrote, "Their dullness seems to be racial, or at least inherent in the family stock from which they come." And these truths, these scientific truths, joined what were already gendered stereotypes of Latinx people, women as hypersexual and hyperfertile, and men as violent and prone to criminality, and became the basis of biology and race and hereditary. Between the early 1920s and 1950s, approximately 20,000 other people were sterilized in California state institutions because they were declared mentally ill and or disabled. But again, These themes never leave our science. They never leave medicine. They never leave the politicization of being undocumented. The theme of separation continues to this day as immigrants are moved into detention centers. And as we learned in 2020, forced sterilization continues, in particular amongst immigrants and in particular amongst Latinx immigrants. I bring you back to consider who were the physicians who carried out these sterilizations, and what was it? What was it that we taught them in medical school and in their training that allowed them to view these people, certainly separated by walls, certainly separated or classified as undocumented, likely separated by language and unable to advocate for themselves, to believe that sterilization and forced sterilization were appropriate, were moral, was ethical. Mass incarceration is also a major issue amongst the Latinx population in the United States. We know already that the United States has the highest incarceration rate of anywhere in the world, but do we know that 1 in 6 male Latinos will be incarcerated at some point in their life? What does this mean for their families? And what does it mean in particular that the Hispanic population in state prisons is as high as 60% in New Mexico and 40% in Arizona and California? What does it mean when we fail to control things like the spread of COVID in incarcerated populations? When we fail to allow people to vote once they've been incarcerated? When we fail to care for the families who are left behind, or the families who are left without someone to bring home some income, someone to care, someone to create memories that build resilience for their children. Again, this theme of separation leads us to consider housing in our own history with the Federal Housing Administration, because we know that the Homeowners Loan Corporation created racial hierarchies that placed African Americans and Mexican Americans at the lowest rung of that hierarchy and declared them to be of the highest risk. And in fact, used language that promoted redlining, that promoted that to this day, Latinos are 81% more likely to be denied a conventional mortgage. These things that we see in modern day are deeply rooted in our history, are deeply rooted in the maps that we create, in the neighborhoods and the way that they are defined by such man-made structures as expressways, etc. Environmental racism is another big issue that is going to become a bigger issue as we move forward. On average, non-Hispanic white people experience a pollution advantage, meaning that they are exposed to less air pollution than is caused by their own consumption. However, Black and Hispanic people on average bear a pollution burden of 56% and 63% excess exposure respectively, relative to their own consumption cause. This is, of course, determined by local geopolitics and class history, but as climate change is upon us, we also see that this pollution burden will lead to further inequities, because both Black and Hispanic people tend to live in areas where the temperature will rise most rapidly, where water will run out most rapidly, and where the ability to work outside for a full day, given the increase in temperature, will be untenable. This is limited English proficiency is something that I address on a daily basis here at the University of Illinois. I predominantly see Spanish-speaking patients. I teach a great deal to our medical students on the care of patients with limited English proficiency. So I'm just going to define this very quickly, although I am certain that given the location of Stanford and your dedication to health equity, you're very familiar. Limited English proficiency is defined as an inability to communicate effectively in English because people's primary language is not English and they haven't developed fluency yet. They may have difficulty speaking or reading in English, and they will benefit from an interpreter who can translate to and from their primary language. There are over 25 predominant languages spoken in the United States. These are the top 10 languages spoken by native and foreign-born limited English proficient individuals. And you will see that Spanish continues to be the #1 language spoken other than English by this population. We have so much literature over the last few decades already documenting that patients with limited English proficiency have been harmed by their poor comprehension of their medical conditions, their inability to understand treatment plans that are delivered in English, discharge instructions, and that they face a great deal of complications because they are not provided with language concordant care. There is inappropriate and inaccurate follow-up. There's an ineffective or improper use of medications. And when medication errors occur, they are serious. Patients with limited English proficiency face poor or inadequate informed consent. I ask my students every year to guess at what literacy level consent forms are written. But first I asked them if we were serious about communicating, at what level would we actually write our forms? And they know that if we wanted to capture as many people who are literate as possible, we would write our forms in 5th or 6th grade level of literacy. In fact, informed consent forms have so much legalese that they are written well above the college level. And so as much as we may try to interpret these forms in English to our English-speaking patients, imagine the difficulty in interpreting them for our Spanish or other language-speaking patients. While hospitals have been held liable for the harms endured by limited English proficient patients, the liability has not been enough to change practices across our countries. And in fact, patients with limited English proficiency continue to endure longer hospital stays, longer emergency room visits. They face a greater probability of admission. They are charged more because we order more tests. Because if you're in the emergency room and a patient comes in with abdominal pain and you cannot communicate that very important history that most often, better than any other test, gives you the diagnosis, then you're going to order the CAT scan. Patients with limited English proficiency also receive fewer preventative services, and when they do present for care, often have advanced disease. But that argument, the argument of quality, is not enough to drive change. What about hospital stays and readmissions? This is a wonderful study demonstrating that readmission events actually drop significantly when we provide an interpreter either at admission or discharge, and they drop even more when we provide an interpreter at both admission and at discharge. We should also be driven by the law to provide language concordant care. This was first established by the Civil Rights Act in 1964. It was driven by an executive order by President Clinton, reaffirmed by President Bush, reaffirmed by the Office of Minority Health, and then again in the Affordable Care Act, which combined class standards and the Civil Rights Act. And yet, the culture in medicine is not to reach for interpreter services when a patient presents who is limited English proficiency. Instead, physicians routinely underuse professional interpreters even when they know that they are being studied. And they do this due to perceived time constraints. And I shouldn't say perceived, these are real, right? We are all seeing patients as quickly as we can in often limited resource settings. At the University of Illinois, I have 20 minutes to see new patients I've never met before, patients with very complicated histories, and often patients who do not speak English. And I thank God every day for my proficiency in Spanish. We do not value bilingualism in this country. The very term limited English proficiency tells it all. It is the fault of the patient. Even though English is not recognized as the official language of the United States, we blame our patients when they don't speak it. And we fail to value bilingualism. We should see it as an absolute asset. We should be driven in our holistic reviews to hire residents to bring in medical students who already speak another language with great proficiency. And we should give them the opportunity to hone their medical language skills in that language. We should be providing them with the opportunity to undergo CCLA testing to make sure that they are prepared to care for patients without an interpreter present, if that's what they wish to do. And or we should be training them on the appropriate use of interpreter services, either in-person, video conferencing, or telephonic conferencing, to drive higher quality of care for our patients who do not speak English. I'm sure I don't need to remind everyone the dire consequences of not understanding or tending to our Black and Hispanic patients when the pandemic came to us. This was a study done out of Cook County Hospital here in Chicago by Trick et al. And you'll see the documentation of influenza during 2019 and the 2020 season and the impact of hospitalized patients here in Chicago. And you'll see what we've all gotten very accustomed to seeing, which is that Black and Hispanic patients suffer a higher rate of being hospitalized with influenza and now with COVID. What you may not recognize is that the public policies that we put into place to protect patients during the peak of the COVID pandemic failed to protect Hispanic or Latinx patients. Why? Well, one reason may be that we fail to recognize that actually Hispanic and Latinx patients live in multi-generational households. And that not only do they live in multi-generational households, and that over 70% of households include both documented and undocumented immigrants. And that amongst those documented and undocumented immigrants, the rate of essential workers is significantly higher than that amongst the white population. In fact, in my family, amongst my 5 siblings, 100% of us are essential workers. This is true for Hispanic families across this country. It is true for our migrant farm workers and continued to be true during the pandemic, that 90% of the food, fruits and vegetables placed on Americans' tables were picked by Hispanic migrant farm workers who have no protections. And the structural violence continues. There's a great need today for Hispanic or Latinx physicians. The rate and the lack of diversity is stunning. The stunning rate at which we dismiss residents who come into specialties who are either Black or Hispanic is stunning. Over the next 15 years, the AAMC estimates that we will need to increase the number of full-time physicians by about 136,000 full-time physicians. More than 2/3 of this growth is associated with demand for racial and ethnic minority populations, including an incremental 47,000 FTEs just for the growing and aging Hispanic population. This is not all language driven. This is, of course, also culture driven. We need physicians who understand the very full and rich and diversity within Hispanic cultures. The diaspora is broad. This is my final slide and my final plea for all of us to look for opportunities to disrupt structural violence. This slide, this graphic is actually the result of a literature review of over 6,000 titles of papers written related to bias within the medical profession and addressing both explicit and implicit bias. Explicit bias has actually dropped significantly in the United States up until about 2017, and then it began to go up again. Implicit bias amongst physicians has remained about the same over the last few decades. We know that we take our learners, medical students, and house staff, and we teach them racialized medicine, right? To this day, we continue to, many hospitals, maybe not Stanford, I don't think Stanford, continues to provide formulas for pulmonary function testing, for glomerular filtration rate that take into account race. We continue to practice in our DoM clinics with very little teaching to how different diseases appear on different colors of skin. So we continue to practice and teach racialized medicine in a setting with very limited diversity, because we know that we don't have enough diversity amongst physicians and diversity of every kind. We have significant cognitive load, right? Our patients are sicker than ever. We're asked to treat them quickly and to move through our days as quickly as possible. And then we subject our learners, medical students, and house staff as well, to a biased learning and work environment. And in fact, the last two reviews that were done demonstrate that about 30% of our women continue to work in a sexist work environment, that about 30% of our Black and Latinx house staff and medical students feel that they are constantly facing microaggressions, and our LGBT physicians are as well. And so we've created an environment with racialized medicine, limited diversity, cognitive load, time pressure, and a biased learning and work environment. And we pass the fruit of that environment on to our patients. As an example, I'll have you pretend to be this physician or learner in the center of the graphic, and you're going to care for a patient here on the right, this blue patient who comes in with hypertension, and you provide them with prescriptions for 2 antihypertensives. You send them out to their community and tell them to access healthy green spaces, to reduce salt in their diet, to enjoy exercise, and you have them return a couple of months later. They return to you a couple months later, and lo and behold, their blood pressure is well controlled. And you say to yourself, wow, I'm awesome. Love my patient. I'm good at this medicine stuff, and it's a beautiful world. You turn now and you care for a very different patient, a patient who also comes to you with high blood pressure, whom perhaps you cannot communicate as well with, whom you also send out with 2 antihypertensive prescriptions. You tell them to lower the salt in their diet, to experience more green spaces, to exercise. And they return, and they've only managed to fill 1 prescription, and they're not able to communicate with you that they haven't managed to find green spaces in their environment, that they haven't managed to incorporate exercise into their day because of their work experience, that they haven't been able to follow through with all of your recommendations. And lo and behold, their blood pressure is not well controlled. What is a physician or a learner to say to themselves? The most likely response is, I know I'm good at this medicine stuff. Perhaps there's something wrong with this patient. And then we get into confirmation bias, right? The stunning thing about, for me, about reviewing these 6,000 titles was how painful it was. Not only to review the 6,000 titles, but how painful it was to review study after study, demonstrating that when we don't provide language concordant care, when we don't address our bias, we actually deliver a lower quality of care to our patients. We actually don't see health outcomes that we could be seeing. And we actually aren't doing our best, and we don't even recognize it. The other stunning thing was study after study demonstrating that patients are incredibly good at recognizing when their physicians are biased. And in fact, they are as good as an implicit association test at recognizing which physicians carry high levels of bias towards their patients. And so I think that we have enough literature in place. I'm not going to leave you in this talk by saying we need more studies. We need to pay attention to the studies that have already been done and the messages we've already received and the messages we've really had compounded during this global pandemic, as well as epidemic of racialized violence in our country, and recognize that there are opportunities to change our systems, to deliver better education to our medical students, to change the work environment for our house staff, for our junior faculty, and create an environment where they actually can deliver better care to all patients. Now I'm going to stop there. Oh, actually, I lied. One more. And I placed this here so that I wouldn't forget. That I hope that we all recognize that we can marshal science, education, and medicine for the betterment of everyone in this country. That we can work together to dismantle structures that allow for violence, that allow us to separate humans using language, using documentation, using incarceration and fences and walls and prisons and detention centers, which then allow us to dehumanize these individuals and allow for more violence to occur. We have to begin to address our bias and learn to uphold those values and qualities in the individuals that we recruit to medical school and we recruit to our faculty who are committed to making a difference. And now I'll stop and take questions.
Thank you so much, Dr. Vela. I am having a little bit of trouble starting my video, so I don't know if someone on the tech side can help out with that. But in the meantime, thank you so much for your talk. It's incredibly timely and important. You've highlighted for us the ongoing impact of structural violence and the responsibility that we all bear in stemming its spread, particularly as medical educators. We have some really fantastic questions in the Q&A, and I encourage you all as our MGR attendees to continue to add questions. I was going to open the discussion with a question of my own, taking your talk as a call to action. What steps do you see institutions such as Stanford being able to take that augments pipelines for underrepresented minorities to pursue and then be retained in careers as physicians and in the medical professions in general?
Yeah, I know that Stanford has a center of excellence. I believe it's run by Dr. Thomas. I would give her all the full funding she can take because I think that she is running pathways programs that recruit diverse individuals who have these skill sets, who have the cultural wherewithal, who have the language to care for diverse groups of patients, and that will alter the culture at Stanford and continue to alter the culture of Stanford and impact the people around them who are practicing medicine as well.
Thank you so much. We'll move along to some of the questions that we have in the Q&A, and again, inviting everyone to continue to add those. What suggestions do you have for institutions to accommodate the necessary increased time needed to communicate effectively with patients that need an interpreter?
I think that if there is a provider who is willing to take on a large volume of patients who will need interpreters present, that provider should be given more time per patient to see that patient. I think it is unconscionable that institutions are not reimbursed for interpreter services. I think there needs to be political action to make this happen, because I think as soon as it happens, people will see interpreter services available across hospitals. I think that much as we love to move through our day and see as many patients as possible and bill as high an RVU as possible, there needs to be accommodations made for physicians who recognize that some patients are being left behind from the highest quality of care, and they need to be given the grace to see those patients and deliver that highest quality of care.
Thank you so much. Another question from our Q&A. There's a growing movement to collect social determinants of health, including race and ethnicity, in the electronic medical record. What role does this play in reducing structural racism or violence?
I think this is a phenomenal question. And I think that not only is there a growing movement to do so, there's a growing movement against doing so. And I'm going to give you a very specific example of a clinic where I practiced, where we drilled down and looked at how well we were managing hypertension amongst all of our patients. This particular clinic cared for a very large African-American population. When we drilled down and studied our own selves, we found that blood pressure control was wonderful amongst our white, well-insured patients, but we weren't doing as well in reducing hypertension amongst our Black patients, right? And as we were reviewing all of this during a committee meeting, we were actually joined by a hospital administrator who said, you know, if you fix these numbers, actually, we will give you an incentive. We are going to give a financial incentive to those physicians who meet these quality standards. And a number of us said, wait, hold on one second. Let's take a look and see which physicians are seeing which patients. And when we drilled down, we found that it was women, junior faculty, and faculty of color predominantly seeing patients who were uninsured and patients of color. So if we had moved forward with these financial incentives, we would have been incentivizing physicians who were seeing well-insured patients with tons of resources to address their medical issues. Instead, once we looked at the numbers and were able to drill down in this way and face what we needed to face, we decided not to accept the financial incentive from the administrator. And as a clinic, we decided to actually use that money to hire an additional social worker to help us provide for patients with lower types of insurance and improve our metrics where we needed to improve our metrics the most. I think without this data, without a willingness to look at this information, we are going to continue to drive disparities and deliver more structural violence to patients.
Thank you, and thank you for the really thought-provoking question. Here we have a question that shifts gears. Tech literacy is becoming a barrier to healthcare. Do you have suggestions on how to assure inclusive digital care to all patients?
Yeah, so I'm not sure that I completely agree with the statement, right? I think tech literature could be a boon for all patients. It is currently not. Why is it not? it is not because we see that there are disparities in availability of digital resources for all patients, right? We know that when we enter a room and we stare at our computer screens, we lose the patients sometimes, right? Same thing happens with interpreter services. If we bring an interpreter into a room and we stare at the interpreter while we're speaking to the patient, we lose the patient, right? We need to better utilize the tech that we have and make it more equitably distributed, more equitably available to everyone. So during the pandemic, when we were all doing telemedicine, how many of us were able to deliver telemedicine in languages other than English? How many of us were able to deliver telemedicine in areas that don't have digital resources, that don't have access to great internet, right? We need to address those issues, and those are bigger societal issues, so that we can actually leverage technology to create more equity. So I'm not afraid of technology. I'm afraid of the human impulse to corral that technology where it's easiest to corral it.
Wonderful. We have two questions that are about working with limited English proficiency patients. I might paraphrase them into one, but one of our participants writes, wonderful presentation. Do you have recommendations on best practices on training our students and trainees for working with interpreters for these limited English proficiency patients? And then in parallel, should Spanish language training and demonstrated conversational proficiency, either in Spanish or some other second language, become a requirement for undergraduate medical training?
Whew. Y'all love to ask great questions. So the first question I'll answer by saying that you can go to the AAIM website, where I actually contributed the best practices for teaching on how to work with medical interpreters and utilizing interpreter services for patients who don't speak English well. And a lot of it has to do with positionality, recognizing power, and recognizing when an interpreter is doing a good job and when they're not. For example, if you ask a patient, do you have pain? And the patient goes on for 60 seconds in response, and the interpreter turns to you and says, no, no pain, pause and say, I want to hear everything the patient said, right? You have not done justice to what the patient said until I've heard everything they've said. So lots of good tips on the AAIM website. The second question I'm going to take as a double-barreled question. Should we be providing medical Spanish coursework in medical schools? I would say yes, if we can guarantee that students who are taking this coursework are already highly proficient in that language, whether it's Spanish, Cantonese, or Arabic, doesn't matter. And number two, we are using standardized measures to make sure that upon graduating from that coursework, we have demonstrated they are highly proficient not only in speaking the language, but in speaking it in clinical settings. And if they plan to become interpreters, that they have 100 hours of practice interpreting alongside a trained interpreter. And that's standard. That is standard. Should we be requiring it for undergraduates? I'm not sure about that, but I do think that admissions committees need to see it as an asset, in particular for those languages that are most highly spoken by patients who have limited English proficiency.
Well, thank you so much, Dr. Vela. I believe that we are out of time, but thank you again so much for joining us and to our participants for the fantastic questions and discussion. This is our reminder that next week, Medicine Grand Rounds are back to an in-person, very exciting milestone for our institution. And thank you all for joining us today.
And I want to thank you and say that I am a fan of Stanford and all that you do related to DE&I. I think that Dr. Dunn, I just heard you speak and I just got to say, I love everything that you're doing. May you continue and may you have a wonderful rest of your day.
Thank you, you as well.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.